afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds in Thoracic Surgery. Premier education brought to you at no cost thanks to our host, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to present to you Professor Haiquan Chen, who comes from Fudan University Shanghai Cancer Center, who's going to talk to us about selective mediastinal lymph node dissection in early stage non-small cell lung cancer. And allow me to share my screen.
Good morning. Thank you for the invitation. I'm to be the Ground Glass lecturer in thoracic surgery at Wolverhampton Hospital. Thank you for the invitation from Dr. Eric Lee. Today, my topic is selective mediastinal lymph node dissection in early stage non-small cell lung cancer. According to the guideline reference on the lymph node dissection, all the guidelines still prefer after the resected lung parenchyma, we have to do systemic mediastinal lymph node dissection on sampling. According to the cell paper from GCO, more lymph node dissection is associated with better prognosis in early stage non-small cell lung cancer. Some literatures still request at least number of lymph nodes we have to harvest. So after the surgery, what we found from our surgery, we do a very hard work, and finally we found all the lymph nodes negative, and only one or two stations lymph nodes positive. So for all the lymph nodes negative, that means we did hard work, and we put the patient some potential harm. We do something, it really do the harm to the patient. And I don't think it can improve the surgical quality or improve patient of life. We improved in patient in the surgical quality. Surgeon, we try very hard to minimize the size of the incision or minimize the number of the incision. We misunderstanding minimal invasive surgery equals to small incision or few incisions. We can see this is the before the dissected. This is inferior mediastinal. After the surgery, we have the mediastinal lymph node dissection. We can see we make a much bigger hole than the incision. This is the super we have the lymph node. We can see there's the potential threat to your puncture hole in the severe venous cava or the bronchus. So we can see we make more invasive if all the lymph node is negative. So we propose a concept minimally invasive thoracic surgery 3.0. That concept published in the Annals of Surgery in 2019 under the surgical perspective. The main focus on the minimal resection. So 3.0, minimal incision, minimal resection, and minimal systemic damage. The key of the minimal invasive surgery, we need to keep the normal lung tissue intact and the selective patient undergoing lymph node dissection. Our goal, not just only to minimize the size or minimize the number of incisions. Our goal is to keep our patient live longer and live better. So in 2017, first we demonstrated the concept of selective mediastinal lymph node dissection. And last year, we published an expertise review in the GGO called Selective Mediastinal Lymph Node Dissection. It's vital to avoid excessive surgery for early stage non-small cell lung cancer. The title is a shift paradigm in selective mediastinal lymph node dissection for minimize over surgery in early stage non-small lung cancer. What's the definition? Dissecting the metastatic or potentially metastatic lymph node and preserve non-metastatic lymph node. How can we do that? Predicting negative status of lymph node pre-operatively or intraoperatively according to the tumor imaging. site location and CTR ratio, and intraoperative full section findings. How can we preserve metastatic lymph node? I think there are three ways described to reduce extent of lymph node dissection. The first one, I think we proposed elective median lymph node dissection. The second one is sampling, and third one, lobe-specific lymph node dissection. A very famous trial is XRZ0030. It published in the JGCVET in 2011. We can see patients with sampling inactivated by fluorescein section were randomized to non-further sampling or complete lymph node dissection. Occult N2 disease were found in 4% of the patients in completed resection group. That means in sampling group, we may left 4% positive lymph node in another group. There was no difference in postoperative complications between the two groups. There was no difference in terms of 5-year survival, DFS, and local and regional distance recurrence. How do we predict a negative lymph node preoperatively or intraoperatively? About 12 years ago, we did a retrospective study. We can see proposed a clinical model for predicting N2 metastasis in non-small cell lung cancer, but we cannot able to predict N0 status. And finally, in 2013, we published the retrospective study in Journal of Clinical Oncology. I believe this is the first report on the features of lung cancer with negative lymph nodes, adenocarcinoma cytome, minimal invasive, adenocarcinoma lipidic predominant adenocarcinoma, or squamous cell carcinoma, peripherally less than 2 centimeters. According to the study, we found and analyze 8 diagnosis. And the GGO accompanied editorial additional step towards the personalization of surgical care for non-small cell lung cancer. And the following year, ESMO guideline adopted this GGO paper. How do we predict negative lymph node metastasis in invasive non-small cell lung cancer? We do the retrospective study. It published in ATS in 2020, and we summarize 6 preconditions to predict mediastinal lymph nodes inactive. Then we do a prospective clinical trial, ESTAL 1007. Finally, we enrolled 100 patients, over 700, to apply for the 6th condition. Finally, with the 6th condition, predict the mediastinal lymph node inactive 100% accurate. This story is published in the GGO in 2023, and also the GGO accompanied editorial. The title is Selective Mediastinal Lymph Node Dissection. It's precise surgery in the area of precision medicine. And after that, we study another ECAL 1009. It's phase 3 randomized trial. This is the first multi-center phase 3 randomized trial on the lymph node dissection for the GGO-dominant lung adenocarcinoma. The surgical strategy, the surgery should be the lobectomy or segmentectomy, and the specific surgical strategy is determined by the surgeon themselves. The two groups without the lymph node dissection, the surgeon does to resect the mediastinal lymph node dissection. It's up to the surgeon to decide whether to perform the higher dissection. The systemic mediastinal lymph node dissection will, and for the right and for the left, according to the guideline requested. The endpoint, the primary endpoint is 3-year DFS, and the second endpoint, perioperative indicator, and surgery time, blood loss, chest tuber retain time. In the sample size calculation and early determination, this study adopted a non-inferior design with a non-inferior threshold at 5%. The sample size calculation is based on the expected 3 years DFS at 96%, detection power of 80%, and alpha value is 0.05, using 1.1 1-to-1 randomized group ratio. The final sample size required for the study is over 638 cases. To ensure the patient safety, this study has established strict midterm analysis and determination criteria. We can see after 300%, the second midterm analysis, and the 302 patients enrolled in each, totally enrolled, and half of the patients assigned to the each arm. We can see the baseline of the two groups of the patient had no significant difference regarding baseline characteristics. Compared to the systemic lymph node dissection, no lymph node dissection has significant better preoperative outcome. There's surgical time is dropped 32% drop. Blood volume loss is 46%. Post-operative catheterization date dropped 10%. Post-operative hospitalization date it shot 30%. So, regarding whether it was systemic lymph node dissection or no dissection, all the patients had no lymph node metastasis. There were no significant difference in the pathological subtype. All invasive is invasive adenocarcinoma. The T-stage EGFR mutation status between the two groups is all balanced. The preliminary survival rate during the midterm follow-up analysis, either group of the patient experienced tumor recurrence or death event. The disease-free survival rate and overall survival rate of both groups were 100%. So the GGO also accompanied this paper, and Dr. David Jones read the editorial. He means this study, which may change clinical practice, provided patients with more precise surgical strategies. So in the meantime, we have another trial to selecting mediastinal lymph node dissection. The ESTAL 1018 is selecting mediastinal lymph node dissection for CT1N0M0 invasive non-small cell lung cancer with CTR greater than 0.5, located in the apical segment, a single-arm multi-center phase 3 study. So totally, we try to enroll over 600 patients. Now the patient is under recruiting. The primary endpoint is 5 years OS. The second endpoint, lymph node dissected in different pathology subtypes, and RFS up to the selection lymph node dissection, and the coordinates between the incorporative FS and the final pathology in assignment in the invasiveness. And second, ESTAL 1-17 is selective mediastinal lymph node dissection for invasive non-small cell lung cancer with a CTR greater than 0.5 and less than 1. The size under 2 centimeters, a prospective single-arm multi-center is 3 trial. This means if the invasive adenocarcinoma with GGO component, if tumor in upload, we don't have to do the inferior lymph node dissection. But tumor in the low lobe, we don't have to dissect it. Superior mediastinal lymph node dissection. the trials is under recruiting. And another one, we try to use the PET CT in predicting lymph node positive or negative in the T1 to T2 non-small cell lung cancer. We work with our radiologist. We use the new molecular probe, Gary 1650, to indicate as a marker to predict the lymph node positive or negative. The primary endpoint to predict the accuracy of the new molecular probe to predict mediastinal lymph node in T1 or T2 non-small cell lung cancer. The second endpoint, the predictive efficiency of PET for lymph node dissection in subsolid or versus solid. Difference in the prediction lymph node between the two probes. The patient are completed recruiting. I think will be released the result soon. The primary analysis, we can see all the accuracy for the 5P, the AOC covered at 0.965, is much better than the FGG, only 0.858. So that's the as per the review that published last year in the GTC that we can see the first the two-stage lung lobectomy that happened in this country. Some of that, a lot of over 110 years. Surgery for the lung cancer, not too much to say, not like the medication, only several, lot of new drugs come up. So for the surgeon, we have a lot to do to do the personalized strategy for our patient. And also in this review, we mainly about the surgical extent of lung, even for the peripheral or central less than 3 centimeters, we can see we can do a lot of individualized surgery for lung parenchyma resection. And for the lymph node dissection strategy for the skin lung cancer, I think with in the near 5 years, there will be more specific, more personalized strategy for how can we do the mediastinal lymph node dissection. Thank you for your attention.
Thank you very much, Haiquan. It's an amazing presentation, and also, thank you for leading the world in finding out what's the correct approach for mediastinal lymph node dissection. We've got some questions from the audience. In the first instance, Dr. Patrick Yu is asking, in your study, the no lymph node dissection arm, is that completely no dissection at all? Or is it selective lymph node sampling?
Yeah, there are several preconditions. We mean the first we give it a definition of selective mediastinal lymph node dissection. It pre or intraoperatively we to predict lymph nodes negative status. For this special clinical study, we know the result from our clinical trial published in the GGO in 2023. Only one station for this group of patients. We know there are 0 lymph node positive in the mediastinal. So for 2 arms, 1 arm we need to harvest all systemic mediastinal lymph node dissection. Another group, we don't have to, but incidentally, you do the segmentectomy or lobectomy, maybe you just incidental to have the lymph node around the bronchus or around the vessel or the lymph node in the hilum, not in the mediastinal.
But for the randomized trial on the no lymph node dissection group, nothing is touched, right? You do not do any lymph nodes.
Nothing. Keep all the mediastinal intact.
Excellent. And so those are for CTR less than 0.5. And so for that group of patients, what you're advocating is that you do not do any lymph node dissection, because all the lymph node dissection increases the harm and there is no benefit from the node dissection itself because there's no metastases in these patients.
Yes.
That's an amazing finding.
Yeah, to our retrospective study for this kind of group is 5 years survival rate over 96%, DFS over 96%.
That's excellent. Now, can I ask, the IASLC have issued guidelines for R0UN uncertain resection, and they expect us as surgeons to do 3 mediastinal stations, including station 7, as well as 3 N1 or more distal stations. Many speakers over the last, in 2025, this year, have moved away from systematic lymph node dissection. And certainly we can see from speakers like Sunichi Watanabe from Japan, for example, only do lobe-specific lymph node sampling. I presume the next step with your leadership in China will be whether or not we need to do lobe-specific lymph node dissection for the upper lobe tumors with a CTR more than 0.5. Is that correct?
Yeah, you can. That's why I introduced. We have another 2 trial ongoing. For the GGO component. That then the CTR ratio less than one. We found that if the patient with the invasive adenocarcinoma, but the real GGO component, we never seen mediastinal lymph nodes cross mediastinal. That means it's compliant to the Japanese colleague preferred lobe-specific mediastinal dissection. We are. I think the JCOG 1413 they started. But the results haven't opened yet, and that the rationale and is on the Dr. Asamura's article is published in 1999 in the JGCS. And we in our retrospective study, we found that the lesion in the upper lobe and very rare to the inferior mediastinal lymph node positive, but still around 2 to 3%, mostly 5%. But in the low lobe, there are over 10% will happen in an up mediastinal lymph node positive. So even the XRZ 0030, we all know the result. Still, a 4% negative, negative lymph node, is real positive. So that means in one arm we found 4% about the positive lymph node. That means another arm we left 4% positive lymph node in the patient. And I believe for the OS DFS, there are no bad difference, but for that 4%, I think the patient will get, if left positive lymph node there, still the patient not good for that small group of patient.
But presumably, if it's PET negative, then the risk of positive lymph node disease is much lower. In the Violet study that we did in the United Kingdom, which I led, the nodal upstaging for PET negative nodes was around 5% as well. But I guess you are also going to investigate the utility of PET to determine how much lymph node dissection we need to do.
Yeah, before had PET is not a reimbursement by the medical insurance, so we don't have that many data. But just the last 10 years, we do a lot of PET. The paper we will publish soon for the PET, negative predictive value, over 90%, still, maybe there possibility we'll have the fourth negative lymph node there. So another study, we used the new molecular probe, Gary 68 FAPI, is much better than the FGG pad. That study we completed recruiting the patient. I think in the next 2 months will be published that data. So maybe the new molecular probe can do better than the FGG pad.
In your slides on your study, when you say apical tumors, do you mean upper lobe tumors or tumors specifically in the apical segment?
Yeah, another you read very careful. In another study, we no matter it's adeno or it's squamous, if in the apical segment, if the lesion in the apical segment, we never seen the patient have inferior medial lymph nodes positive.
Right. So for your entry criteria for your next study, you refer to the apical segment of the upper lobes.
Yes, if the lesion in the apical segment, we don't have to have the lymph nodes in the inferior mediastinal.
Excellent. Again, that's going to really change the way we practice across the world. Can I ask your current practice in China before the results are out? For tumors in the upper lobe alone, let's say not in the apical segment, would you do a full systematic nodal dissection, or do you do lobe-specific nodal dissection?
Yeah, that's a very good question. In my center, if the patient don't apply for the precondition, we know exactly the lymph node is negative in the mediastinal. We'll do the systemic mediastinal in lymph node dissection according to all the guidelines they requested.
So you do all the upper and lower stations.
Yeah.
2, 4,
Yes.
7, 9, 8.
Yes. Yes.
Excellent. That's very good.
But for the upper lobe, we seldomly to do level 9. We do the subcranial. But where we do the station level 7, level 9.
No, I think you make good points. The Royal Brompton has traditionally been following the practice of Professor Peter Goldstraw, who's always advocated systematic lymph node dissection. And I'm pleased that now, in China, and you have done very many randomized control trials, which really helps us guide our practice going forward for the future. As always, there are too many questions and we never have enough time for the answers. So which leads me to thank again our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. And also especially to you, Haiquan, for being able to lead clinical trials in China. We know how difficult it is and how much volume there is. And for leaders like yourself to be able to utilize the volume and to translate that into trials, which changes thoracic surgical practice across the whole world. I just want to say many congratulations and thank you on behalf of the international thoracic community.
Thank you for inviting me, and Eric.
Thank you very much. Have a good evening.
Thank you.
Goodbye. Bye.